Muchas gracias. Cambiamos un poco el orden de las charlas. La siguiente será del doctor Adi Weintraub, que nos hablará de las nuevas técnicas regenerativas en lesiones esfinterianas.
Okay. You know, now it's the hardest part of the day. After lunch, and everything is comfortable, and this is probably the hardest lecture because it's a lot of basic science what I'm going to talk about. I must say when Joan asked me to talk about the subject, I must admit it's not a subject that I personally research. It's basically what I did is a literature research, but it's fascinating. Okay, so I hope I'll try to give an overview of the topic and not go too much into depth, but if it's too much, let me know. Okay, so we talk about anal incontinence and oasis, and when we look at the hands, our hands, it's a remarkable organ. We can do so many things with the hands. We have gentle motor skills, and we have power. We can give a punch, and we can pat, and we do a lot of things. But if you take a matter that is combined with gas and liquid and solid together, you can't separate them through your hands. In that respect, the anal sphincter is much better. It was Walter Borenmeier who said that there's no greater protector of human dignity in the body than the anal sphincter. When we talk about anal incontinence, then again, a little definitions probably everybody knows, so I'll go over it quickly. We talk about fecal incontinence, which is the involuntary loss of solid or liquid feces. Anal incontinence is involuntary loss of feces or flatus. And oasis, as you know, is the obstetric anal sphincter injury, which is the major cause for fecal incontinence and anal incontinence. When we look on the epidemiology, the rate, fecal incontinence in both men and women, by the way, is around 7 to 15% of the population, and anal incontinence is even more common. And after oasis, it's really, really common. The rate of oasis is 1 to 6%. Of course, depends if it's primiparas or more, but most of the literature is talking about 1 or 2 to 6%. And anal incontinence after oasis can reach even as much as 50% of patients. We're seeing a trend worldwide where the rates of oasis are increasing in England, in Sweden, Norway, Finland. We saw, actually Finland is one of the lowest places in the world when we talk about the rate of oasis. And anal incontinence, of course, is a major cause for decreased quality of life. It affects all aspects of quality of life, all activities like travel, sleep, work, physical exercise, and sexual function. Now, the current treatment options are either supportive care when we talk about women with anal incontinence, on a diet, on hygiene measures, incontinence pads, or medical treatment like bulking agents and anti-diarrheal drugs and enemas, for cleansing, and subsequent management that will include physical therapy, biofeedback, injectable bulking agents, anal sphincteroplasty, sacral nerve stimulation in some cases, and of course neosphincter or deviation colostomy in the most extreme cases. I think you can all agree that none of these treatments are ideal, because even after treatment many women remain incontinent. So the development of new treatments is an important priority, research priority, and clinical priority. Now, when we look about new possibilities, we can look into regenerative medicine. And when we talk about regenerative medicine, we talk a lot about stem cell therapy. Stem cells are cells that have the capability to self-renewal and to differentiate, okay? And they're, as you see, it could be either symmetrical. From one stem cell can be two daughter cells that are also stem cells, or asymmetrical, two daughters that are stem cells or differentiated cells, or asymmetrical. From one cell could be two cells, that one is a stem cell and one can differentiate. There are three main uses for stem cells. One, as therapy. We can use stem cells to regenerate lost or injured tissue. The second is it could be a target of therapy. We can use stem cells to be like ligands to antibodies or to all kinds of drugs that are specifically engineered to go to these cells. And as disease models, I mean, we can grow tissues or cells and do experiments to develop new drugs and new treatments. When we talk about stem cells, we talk about potency levels from totipotent, which is the primary cell seen in blastocysts that can differentiate into all the lineages of the embryo, but also the extra embryonic tissue. Pluripotent, which is all levels of embryonic tissue. The multipotent usually have one lineage, like nerve, blood, other tissues, and that's the unipotent. The sources of stem cells today are embryonic stem cells, which we can take like from blastocysts, 7 to 10 days old. Of course, it poses some ethical issues because it's cells that theoretically are human matter. There are adult stem cells that exist in tissues with a high turnover, high renewal, like the skin, blood, intestine, okay, and they're progenitor cells in these tissues. And there's what we call iPS-induced pluripotent stem cells, which are reprogramming. There are methods today to take cells and make them go back, become more and more primal until the stage that they are multipotent or pluripotent. This, of course, has changed dramatically the whole thing, because you can take any cell lineage and bring it back and make new tissue out of different kinds of tissue. When we talk about regenerative medicine, we're talking about the process of replacing, engineering, or regenerating human cells or tissues or even organs to restore and establish normal function. If you look at the picture, you see there's a patient. We can take, for instance, a skin biopsy and use skin fibroblasts, and through this nuclear reprogramming to make them into pluripotent cells, which will differentiate. We can also control the differentiation into disease cell type, for instance, nerve cells, okay? And these nerve cells we can use either as a disease model and do experiments and look for drugs, or as cell therapy and return them back to the body, okay? So we start off with skin and we end up with nerves that we can use. If we look briefly at the history of this path of science, then in the early 20th century, the existence of stem cells has been hypothesized. After World War II and the use of radiation due to the bomb, the nuclear bomb, the stem cell used for therapy was first explored and led to the first demonstration of these stem cells that up until then was only theoretical. In 1963 in Toronto, the researchers demonstrated that the bone marrow-derived cell could replace all the blood elements by the infusion of blood. And then in the next 20 years, it became very stem cell therapy, hematopoietic stem cell therapy became very established, and it is like what we know it is today. In 1975, there was a report of possible use of cells from the skin for the treatment of severe burns, and then we have we grow tissue, skin tissue, and pads for severe burns. And today we have additional uses, and we're looking at in all kinds of fields, in orthopedics, like bone grafting, ophthalmological corneal regeneration, and there's research about muscle and nerve tissues, and specifically muscle is what we're talking about here. Still, there are many, many challenges in the stem cell therapy. Of course, the tissue integration. Okay, I have cells. How can I make sure that they will be integrated wherever in the exact place I want them? Or specifically, when we talk about anal incontinence and oasis, in the anal sphincter. Oncogenesis. Can the cells that I'm returning to the body become oncogenic? How can I direct the differentiation exactly to the cell lineage that I want? Or to stop the differentiation exactly in the stage that I want? And there's issues of uniformity and consistency with different cells from different specimens. And of course, ethical considerations that we've mentioned before. So when we talk about anal incontinence and regenerative medicine, then it provides us an alternative strategy for the treatment of incontinence. Continence for stool and gas is maintained by a complex sensory and motor interactions between some of the things that Camille showed us before, the rectum, the external and internal anal sphincter, and the puborectalis muscle. And anal incontinence occurs when one or more of these structures is injured or is malfunctioning, okay, like after perineal trauma. And it makes these structures a potential target for regenerative medicine. So as I said, research has focused in the past years on using skeletal myogenic cells. So let's see. In the external anal sphincter and the puborectalis muscle, they're striated skeletal muscles, and they have the satellite cells that are progenitor cells and can be developed into additional muscle cells. These satellite cells are localized between the sarcolemma and the basal lamina of normal muscle fibers. In adults, they're usually dormant and are activated when there's an injury, and they create new and innervated muscle fibers, which is very important for this target. With regard to studies that have been done, so cells have been injected into the external anal sphincter to intact external anal sphincter and injured external anal sphincter and injured sphincter that after a period of 2 to 4 weeks, and they saw that cells survived and integrated into the recipient tissue. The recipient are animal studies, yeah, about rats and maybe additional, I think, pigs also. And the improved regeneration was observed histologically and in functional tests. And another important thing, there was no distant migration of the cells that were implanted to other parts of the body. And then they started to do also very preliminary studies on humans. This study from 2010, about 10 women with anal incontinence following obstetric trauma, were injected with autologous muscle-derived cells into the external anal sphincter. And after 1 year, they were observed significant improvement in anal incontinence, but the external anal sphincter thickness and the resting and squeezing pressures were unchanged. So, and after 5 years, pressure significantly increased, and there were no adverse events, meaning so that it was relatively safe, although it's questionable how effective the treatment really is. And of course, there's also case reports that started to appear. Again, when we talk about skeletal myogenic cells, there's all kinds of strategies. We can do culture expansion, grow them in a dish, okay, but this is very time-consuming and very expensive. Another option is what they call Frenchly minced fragments, to take a tissue biopsy, a muscle biopsy, and to mince it and then let the progenitor cells, the satellite cells, be separated. Another source of cells is the mesenchymal stem cells. They're much more prevalent and are existent in additional tissues like the fat tissue. They're easier to isolate and they are multipotent. They may differentiate to many tissues, including skeletal and smooth muscle cells, which is ideal for both the internal and external anal sphincter repair. Again, there were some preclinical studies on animals investigating either direct injection and some also injection IV. They saw improved regeneration of both the external and internal anal sphincters, both histologically and functionally. And they think that the part of the response, especially when it was injected IV, could be due to some kind of a paracrine stimulation. And studies in humans are ongoing, and still not all of them have the results. A third strategy is bioengineering of the internal anal sphincter. The internal anal sphincter accounts for 70% of the resting anal tone. It's innervated by the autonomous and enteric intrinsic nervous system. Between defecations, there's a constant basal tonic activity, and during defecation, there's a transient relaxation. Again, here in some preclinical studies, in vitro functional bioengineered human internal anal sphincter was successfully developed. The bioengineering means that they prepared like a scaffold on which the cells grow or regenerate. It was implanted into rats, and after 4 weeks, the internal anal sphincter constructs were harvested, and functional tests demonstrated internal anal sphincter function, basal tone, and relaxation. I'm really getting close. Okay, so these are clinical trials that some of them are on the way, and a few there have already been published. Another thing that should be mentioned is, except for the harvesting and growing of these stem cells, as we said, there are all kinds of cytokines and paracrine activities that take action, and one of these cytokines of interest is let me go forward just a second, is this, the CXCL12, which is a cytokine. It's also called SDF1, stromal-derived factor 1, and its expression has been found to upregulate during muscle injury. Okay, and it recruits reparative cells and stimulates tissue regeneration. So this is now a new focus, not growing the cells, because it's a big problem, both, as we said before, all the problems of time consuming and very, very pricey, but more to be precise, to recruit these cytokines that can promote cell regeneration. And these are some of the results. Again, in animal, you see here that the first on the left, it's rats that were injected with saline. The middle one is rats that were injected with SFD1, one injection, and the right one were injected with SFD1 in repeated injection after 2 weeks as well. And you see that the muscle fibers are much more organized and regenerated after this. So it's a promising new prospect. Additional directions are electrical stimulation. We know from urological functioning following acute birth injury that there's improved external urethrosphincter EMG activity after electrical stimulation, and there's also upregulation of cytokines after electrical stimulation to the anal sphincter as well, post-injury, and also extracorporeal shockwave therapy with acoustic energy, and again, it activates all these regenerative cytokines to promote not only muscle regeneration, but also innervation from the surrounding. Okay, so in summary, so we say the current treatment of anal incontinence, so either conservative or surgical, is not ideal. Potential alternatives include the regenerative medicine, the stromal-derived factor 1, the cytokines, electrical stimulation therapy, and extracorporeal shock therapy. Regenerative medicine, we talked about the 3 strategies of autologous skeletal myogenic cells, autologous mesenchymal stem cells, and scaffold bioengineering of the internal anal sphincter. And autologous skeletal myogenic cells look very, very promising, but we're not quite there yet, but we're getting there. And again, thank you.